Vanakkam. When a child presents with a small thumb or sometimes no thumb at all, that is the typical congenital hypoplastic thumb, our first work would be to classify it, because that would tell us what are the problems inside and what would be the structural and functional deficit in the thumb. That would guide us about the correct treatment. So before trying to understand the treatment of hypoplastic thumb, it is logical to try and understand the classification and clinical features which will be done in this video. In trying to learn about congenital thumb hypoplasia, we shall see the classification and clinical features of this condition in this video. The thumb ray is the prime ray of the hand. Its size, position, mobility, independence, and relations to the other digits are critical to function. The thumb is considered hypoplastic if any portion of the ray, the skeletal or the soft tissue, is deficient or absent. So obviously there is a wide range of hypoplasia starting from very slight reduction in the size of the thumb to absolutely no thumb at all. Sometimes it is not very easy to identify a hypoplastic thumb immediately after birth of the child. That is because in the first 3 months of life the thumb is adducted and flexed within the palm. It serves primarily as a pacifier. By 9 months of age, the thumb gains independence and mobility from the palm. At 1 year of age, it becomes a crucial part of the hand. You can click on the icon above to see more about the growth of the hand as the child grows. To help us to assess the thumb, we can do an X-ray evaluation. The normal primary ossification centers of the phalanges and metacarpal of the thumb appear in the 2nd to 4th fetal months. But abnormalities of the skeleton of the thumb, like for instance delta phalanx, which means triangular bones, may not be seen radiographically until well into the 1st or 2nd year of life. Secondary ossification centers within the epiphysis of the thumb normally appear between 13 months to 4 years of age. The delayed appearance of both primary and secondary ossification centers in the hypoplastic thumb is highly relevant to the diagnostic process because their appearance is often delayed in proportion to the degree of hypoplasia. Congenital thumb hypoplasia is seen to constitute about 3.5% of all upper limb congenital deformities. But this is variable in various studies because the presentation of congenital thumb hypoplasia is quite varied, and the incidence of this condition is estimated to be about 0.5 to 2 children per 10,000 newborns. Congenital thumb hypoplasia is usually associated with radial or preaxial longitudinal deficiencies which occur in many conditions with a wide variety of etiologies. You can click on the link above to see more about radial longitudinal deficiencies. So the causes of these malformations can be quite varied. They span the entire spectrum of genetic, environmental, teratogenic and other factors. It can be associated with many syndromes like the TAR syndrome, Bacterl syndrome, Fanconi anemia or the Holt-Oram syndrome. You can click on the link above to see more about the features of these syndromes and the occurrence of thumb hypoplasia in these conditions. We need to know the classification of thumb hypoplasia because it will help us in understanding what are the problems that are associated with each type of thumb hypoplasia, understanding how each condition would present, and also understanding what should be the treatment protocol for each type. Just to understand the sequence of how the classification of congenital thumb hypoplasia evolved, the first classification was created by Müller in 1937. The modern classification was developed by Bloch in 1967. It was updated by Mansky in 1992, by Buck Gramco in 2002, by Smith in 2012, and by Tonkin in 2013. In 2006, the Bloth classification was expanded by J. Upton. In 1937, Muller introduced the concept of a teratological sequence of thumb hypoplasia with increasing severity from mild deficiency through severe deficiency to absolute thumb absence. Bloth subsequently detailed 5 specific grades in 1967. In 1992, Mansky and Meckerel altered Bloth's classification such that grade 3 was subdivided into grades 3A and grade 3B according to the presence or absence of the proximal metacarpal. Buck Gramco added a grade 3C in which there was only a remnant metacarpal head. Smith subdivided grade 2 into type 2A and 2B depending on the type of instability of the metacarpophalangeal joint of the thumb. Bloth type 2 hypoplasia of the thumb had many different unique characteristics, and Michael Tonkin subdivided type 2 based on the predominating feature of the presentation in particular patients. Upton noticed that the thumb was hypoplastic in many other conditions also apart from radial longitudinal deficiency. So he added a few categories: type 6 where the hypoplastic thumb is seen in central deficiencies, type 7 constriction ring syndrome, type 8 the 5-fingered hand, type 9 radial polydactyly, and type 10 syndromic short skeletal thumb ray. The type 1 or grade of the original Bloth classification is sometimes known as mild hypoplasia. The thumb appears slender and slightly shorter. The phalanges and metacarpal are slightly thinner than usual, but the joints, that is the interphalangeal joint, metacarpophalangeal joint and carpometacarpal joints, are stable with a normal range of movement. As far as the intrinsic muscles are concerned, there may be slight hypoplasia or weakness, but they are present and acting. The ligaments and capsules, nerves and vascular structures are normal, but there may be a minimal narrowing of the thumb web space. So type 1 congenital thumb hypoplasia, known as mild hypoplasia, refers to a slightly smaller thumb and no discrete absence of structures. The overall function is good with minimal impairment. Type 2 is referred to as moderate hypoplasia. It is characterized by 3 important features: narrowing of the thumb index finger web space, absence of thenar muscles, and instability of the thumb metacarpophalangeal joint but with a normal articulation. The thumb index finger or the first web space is narrowed and the intervening skin is taut. You can make out the narrowed thumb web space in these pictures. The second important finding in type 2 thumb hypoplasia is the absence of thenar muscles, which is very obvious on inspection of the hand itself. This is because the thenar muscles innervated by the recurrent branch of the median nerve, that is the abductor pollicis brevis, opponens pollicis, and the superficial head of the flexor pollicis brevis are not developed. The ulnar innervated intrinsics, particularly the adductor pollicis, pull the metacarpal into adduction because there is no antagonist, and this leads to narrowing of the first web space, which when explored surgically shows tight fibrous bands. As far as the bones are concerned, the metacarpal and phalanges are all present but small, and the trapezium, trapezoid and scaphoid, and to a lesser extent the lunate, may be a little hypoplastic. But the important feature is that the metacarpophalangeal joint is usually unstable with laxity or incompetency mainly of the ulnar collateral ligament. That is demonstrated in this picture from literature. The metacarpophalangeal joint can also be globally unstable with incompetency of both the ulnar and radial collateral ligaments. To summarize the features of type 2 hypoplasia, there is minimal to moderate shortening of the skeletal ray, but all bones are present. The thenar intrinsic muscles are hypoplastic, mainly the median nerve innervated muscles. The first web space is tight and the thumb web space is much narrower than normal. In addition, the ulnar collateral ligament is weak at the metacarpophalangeal joint. Functionally, the key pinch is weak and the patient cannot hold heavy objects between the thumb and digits. This type 2 congenital thumb hypoplasia can be subclassified according to the metacarpophalangeal joint instability as described by Smith and Shivakumar, or according to the predominating feature of the condition as classified by Michael Tonkin. This subclassification helps because the treatment approach differs in each of these conditions. Instability of the metacarpophalangeal joint of the type 2 hypoplasia can be uniaxial, where it is known as type 2A. Here, only the ulnar collateral ligament is lax. It could be multiaxial, known as type 2B, where both the ulnar and radial collateral ligaments are lax. So, there is universal instability in type 2B. Based on the predominating feature of the Bloch type 2 hypoplasia, it can be subclassified into 4 types as described by Michael Tonkin. When thenar muscle hypoplasia is predominant, it is called subtype 2A. When the extensor pollicis brevis muscle hypoplasia is predominating, it is known as subtype 2B. When the flexor pollicis brevis muscle is hypoplastic, it is known as type 2C. And when there is moderate hypoplasia of the supporting and stabilizing structures of the thumb bones, it is known as type 2D. Type 3 congenital thumb hypoplasia is otherwise known as severe hypoplasia. It is known as type 3 hypoplasia when the intrinsic anomalies associated with the type 2 deformity are present, along with extrinsic musculotendinous abnormalities and additional skeletal abnormalities. First, let us consider the extrinsic musculotendinous abnormalities that are seen. They could involve the extensors, that is the extensor pollicis brevis and extensor pollicis longus, or the flexors, which consists of the flexor pollicis longus. There could be abnormal connections or even abnormal muscles that are present. This could lead to absence of interphalangeal or metacarpophalangeal joint flexion or extension, or even sometimes deviation and abnormal movements. As far as the flexor pollicis longus is concerned, many variations can be found. Both the tendon and muscle belly of the flexor pollicis longus may be abnormal, with proximal duplications, abnormal origin or insertion, or sometimes may be absent entirely. Now, we need to consider 2 important types of abnormal muscles. The first is musculus lumbricalis pollicis. It is supposed to be a muscle extending from the thumb across the first web space and attaching to the flexor system of the index finger, which is sometimes seen in type 3 congenital thumb hypoplasia. The extrinsic extensors may have abnormal connections with the extrinsic flexor. So both the flexors and extensors now act as radial deviators at the interphalangeal and metacarpophalangeal joints, helped by the lax ulnar collateral ligament of the metacarpophalangeal joint. This has been called the pollex abductus by Tupper because it ends up abducting the thumb at the interphalangeal and metacarpophalangeal joints. This pollex abductus refers to intratendinous connections between the flexor pollicis longus and the extensor pollicis longus, which may vary between a wide, loose, almost areolar band to a complete coalition of the flexor and extensor into a single tendon. So the resultant movement from either the flexor or the extensor will result in abduction of the metacarpophalangeal joint, which is a totally abnormal movement. As far as the skeletal abnormality is concerned, in type 3 or severe hypoplasia, the degree of skeletal shortening and narrowing is much more pronounced, particularly at the metacarpal level. The hand and wrist may be radially deviated due to hypoplastic or aplastic carpal bones. The trapezium is usually very small and frequently the scaphoid is absent. The distal radius is smaller in size and the styloid process is absent, giving the radius a blunted appearance. So because of the extreme amount of anatomic variations within this group in the metacarpals particularly, Mansky and colleagues subdivided this group into type 3A, which had a full-length metacarpal and an intact carpometacarpal joint, and type 3B with a tapered first metacarpal and no carpometacarpal joint. Buck-Gramco included an additional variation which is called the type 3C thumb, which possesses only the head of the metacarpal. The other findings in type 3A hypoplasia can be a poorly developed flexor retinaculum with attenuation of the major pulleys, absence of the motor branch of the median nerve, and only one neurovascular bundle of the thumb. The radial origin of the first dorsal interosseous to the index finger is severely hypoplastic and the first web space is severely restricted. Pollex abductus anomalies are common and must be recognized if interphalangeal joint flexion and or extension is to be achieved. As shown in this example, these thumbs exhibit more severe skeletal hypoplasia, including the carpal bones. The median nerve innervated thumb intrinsic muscles are severely hypoplastic or absent, and the ulnar innervated muscles may be present but weak. In type 3B thumb hypoplasia, the median innervated thenar intrinsic muscles are absent entirely, and severe hypoplasia of the adductor pollicis, flexor pollicis brevis lateral head, and the ulnar origin of the first dorsal interosseous. The carpometacarpal joint articulation of the proximal metacarpal is absent. The metacarpophalangeal joint is very lax or absent on both the radial and ulnar sides, and the flexor and extensor extrinsic tendons are severely hypoplastic or absent. Clinically, it is very important to differentiate between type 3A and type 3B because the treatment protocols are going to be totally different for the two types. To differentiate, apart from the appearance of the metacarpal, we can look for the ossification of the trapezium and trapezoid, but this ossification does not occur until 5 to 6 years of age. The child often helps to discriminate between a type 3A and 3B during the development of pinch and grasp. If we closely observe the movements of the hand, a type 3A thumb with a stable carpometacarpal joint is incorporated into object acquisition and manipulation activities. In contrast, a type 3B thumb with an unstable CMC joint is often bypassed and prehension develops between the index and long digits. The hand also will respond by widening of the web space between the index and long fingers and pronation of the index finger out of the palm. In type 3C, there are no tendons or muscles in this variant, but the skin bridge is much wider than what you will see in the floating thumb or type 4. In the type B and C variants, a fibrous band may connect the hypoplastic metacarpal to a cartilaginous nubbin that represents either a trapezium or the metacarpal base. Often, a small abductor pollicis tendon attaches to this remnant. Type 4 hypoplasia of the thumb is known as the pouce flottant or the floating thumb in French. It usually lies along the radial mid-axial border, and this nubbin of a thumb is attached only by a soft tissue pedicle which has been described by Littler as nature's own neurovascular pedicle due to the presence of a digital artery, two venae commitants, and one or two nerves within that narrow skin bridge. There is no metacarpal, and usually two small phalanges tend to be present within the soft tissue envelope, which contains a nail representing the terminal phalanx. Intrinsic muscles do not insert onto these bones, and there is no active flexion or extension. Radial deviation of the wrist and hand may be seen due to hypoplasia of the trapezium, scaphoid, and lunate, and the radial styloid may be absent, but the distal end of the radius is normal in most of these children. When there is no thumb at all, it is known as type 5 congenital thumb hypoplasia. It is otherwise called aplasia of the thumb. In this condition, the function of the index finger is very important, and this differs depending on the severity, which is seen by the development of the radius. When the radius is normal, the index digit is normal and has strong abduction at the metacarpophalangeal joint due to the presence of a strong first dorsal interosseous muscle, which is sometimes called the abductor indicis. Many of these children with a normal radius will demonstrate autopolicization, that is, the pulp of the index finger widens and the digit pronates and sits in a more abducted position, resulting in a widening of the intermetacarpal space and attenuation of the intermetacarpal ligament. At best, this posture is a poor substitute for normal key pinch, and the children tend to use the index finger like a thumb. This autopolicization can be noted even in a type 3b or a type 4 hypoplasia of the thumb. In case the radius is deficient, the index ray is stiffer, shorter, and often joined by a simple syndactyly to the middle finger. There is a direct correlation between the degree of radial hypoplasia and index finger deficiencies, and the degree of stiffness decreases from the radial to the ulnar digits, and the little finger is always the best functioning finger on such a hand where the thumb is totally absent. In 50% of the cases, the radius is normal, but the trapezium, trapezoid and scaphoid are often hypoplastic. Upton noted that the thumb is smaller or hypoplastic in many other conditions, and he gave a classification for this. He added this classification to the existing Bloth classification. So according to Upton, type 6 refers to central deficiencies and further subclassified into type 6A, which refers to the typical cleft hand, and type 6B, which refers to the atypical cleft hand or symbrachydactyly. In type 6A, which refers to the typical cleft hand, the thumb is usually small. The median innervated thenar intrinsics are present, but the ulnar innervated intrinsic muscles are severely hypoplastic or absent, particularly the adductor pollicis and the first dorsal interosseous muscle. And the presence or absence of the third metacarpal is often an indicator of the status of the adductor pollicis muscle. There is usually a syndactyly between the index finger and the thumb, and if the thumb is long, there may be a flexion contracture or a triphalangeal thumb. In type 6B or the atypical cleft, otherwise known as symbrachydactyly, the thumb is invariably smaller here with severe hypoplasia or aplasia of the phalangeal components. In atypical cleft hand, because the third metacarpal is intact, a functional adductor pollicis muscle is often present, but it has very weak adduction power. The median nerve innervated thenar intrinsic muscles are intact. The thumb CMC joint is well segmented and mobile, and the interphalangeal joint of the thumb may exhibit decreased passive and active motion due to weak extrinsic flexors and extensors. You can click on the link above to see more about the different types of cleft hand, the typical and the atypical types. Type 7 of the Upton classification refers to the constriction ring syndrome, where the amniotic band sequence can affect one or all the limbs. The thumb in these hands may present with a shallow or deep constriction ring or even an amputation at any level along the skeletal ray. The phalanges at the level of the loss are characteristically narrow and taper distal stump. The proximal anatomy in this condition is normal. In type 8, known as the 5-fingered hand, the thumb is smaller in width and longer in length and has the characteristics of a finger. It lies in the same plane as the ulnar 4 digits and is non-opposable. The thenar musculature, that is the abductor pollicis brevis, flexor pollicis brevis and the opponens pollicis muscles are absent, and the adductor pollicis is also absent. But the first dorsal interosseous, volar interosseous and lumbrical muscles are present in this ray, which anatomically is a finger and not a thumb. So the patient usually tries to flex and autopronate this ray to act like a thumb. The hypoplastic thumb seen in radial polydactyly is classified as type 9 according to the Upton classification. Each partner of this duplicated thumb is hypoplastic to varying degrees, and the complexity of hypoplasia increases as the level of duplication progresses proximally. The extrinsic extensor is almost universally shared between these two partners, and the occurrence of pollex abductus is very common. The final category in the Upton classification is the type 10, which is known as the syndromic short skeletal thumb ray. This refers to deficiencies of the osteoarticular column of the thumb, where we have typically a short hypoplastic thumb. The bony abnormalities can occur as isolated bone problems or all bones of the hand in combination, or as part of a generalized syndrome such as acrocephalosyndactyly like Apert-Pfeiffer and the Carpenter syndrome. Usually in this condition, there is a short thumb with or without a radial clinodactyly, which is a radial deviation at the level of the proximal phalanx. This is because primary osseous abnormalities are usually seen at the proximal phalangeal level in this type of thumb. So, with thumb hypoplasia, we have seen a wide spectrum of functional and aesthetic differences. So, when assessing such thumbs, we need to consider 9 criteria: the size of the thumb, the position of the thumb, the relation to other fingers of the hand, the osseous components that are present, and joint integrity and stability of all the joints of the thumb, the intrinsic and extrinsic musculotendinous units, the first web space depth and width, associated malformations of the hand and elsewhere, and functional consequences for the child. Management of thumb hypoplasia is based on the classification pattern. So now that we have understood the classification pattern, we shall see the management of this thumb hypoplasia in the different types in the next video. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see other congenital hand differences like the radial longitudinal deficiency and the cleft hand. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery and ethics.